What I want to do is really look at the issue of clinical leadership for service improvement from two perspectives. I want to ask two questions. How do you think about leading clinicians, and how should clinicians themselves lead, which I think are for me, the two big questions. Why clinical leadership? Can't we have somebody else take the leadership role, and the doctors and nurses will simply take care of the patients? I think, at least I hear, three classes of reason why we want clinicians much more involved in a leadership role in the NHS and in the US and worldwide. And the first of those relate to power and status. The role of the doctor and the clinician is to hold the politicians honest in the redesign of healthcare delivery systems and make sure that the patients and the need of the patient, the rights of the patient, are fully front and center as we reconfigure something as important as the NHS. The second line of reasoning is the kind of complexity argument. It says, look, biologic and healthcare delivery organizational systems are so complex that only people with a deep and detailed understanding of how the human physiology works, how medicine works, and how medical and care delivery organizations work could possibly take a role in leadership. And the third argument is the microsystem argument. And in the microsystem argument, we observe that the thing that really touches the patient, that really makes the difference in a patient's life and addresses a patient's healthcare needs, is the microsystem, that small group of doctors and nurses and various clinical professions and non-clinical people who come together to actually deliver the care that the patient receives. And if we look in the literature about microsystems and microsystem performance, what we see is that there are lots of operational issues that have increasingly been demonstrated to have a positive impact on health outcome for patients. So at the microsystem level, the need for leadership is to design and implement and oversee and run effective small microsystems that are the atomic unit, if you will, of healthcare delivery. The challenge is, how do we get the will and skill into the hands of a generation of frontline leaders? The next contextual issue that we have to worry about is the nature of a professional bureaucracy. And of course, the most important characteristic is the key worker does not report to the boss. So the workers are highly trained, and they have a large measure of operational control of the day-to-day work. Secondly, those workers are trained in autonomous and individualistic decision-making, where patient care is complex, where concrete rules cannot guide decision-making in many circumstances. You're much better to have an autonomous professional who integrates inputs from multiple components of a system in order to effect the best care for a patient. Similarly, where uncertainty is high, where circumstances cannot be prescribed or decisions cannot be framed by rules, you need an autonomous decision maker. Of course, there is a downside of all this autonomy. Perhaps the most prominent of those downsides, something that the King's Fund has documented in some detail, is the inappropriate variation in practices that is endemic among a large group of autonomous professionals. But also the other downsides are, as I've listed. We tend to see a failure to take a whole system view and to integrate care across multiple components of a complex system. Decision-making is often slow, and there is the power of veto. We used to joke in my last organization that if the vote was 300 to 1, it means you've lost. And then we have distressing examples of a complete failure of peer oversight. So that line of reasoning might argue that you would want to constrain professional autonomy. Well, there's a problem here. There are places where we actually want the autonomy. The problem is that not all of the health problems that we want the clinical community to address are so nicely described by clear science and crisp protocols. There's lots of places where we don't quite know what the right thing to do is. It's the clinicians, the doctors' experience that governs how they perform, not the science. And that's where indeed we need to promote autonomy. So how do you lead clinicians in the context of a professional bureaucracy? Well, the first thing you've got to do is you have to motivate them. The language is very important here. we've tended to fall back on a language of economics and accounting and management, efficiency and mandates. And I don't know about your clinical colleagues, but mine don't warm to this language. They warm to words like service. They warm to the notion of the relief of suffering. We've got to think very carefully about the language that we use, and we have to think very carefully about the nature of the goal around which we are trying to mobilize their collective action, and think very carefully of the framing of the purpose. And framing the purpose as the relief of suffering is going to be a great deal easier than framing the purpose as taking $20 billion out of the NHS budget if you're trying to lead clinicians. What I'm describing is a model of distributed leadership, a model of taking the overarching goals of the organization and stepping them down deeper and deeper and deeper into the organization, so that leaders lead clinicians by giving away authority and giving away power. And as you can imagine, it's pretty risky. You know, I think Sir Robert Naylor from UCH put it best. You know, he said, I feel that I had to have my finger on the pulse of everything in the organization to make sure I knew everything that was happening, and I had control and I could intervene when things went out of line. And after a while, having developed a cadre of clinical leaders, I began to place more trust in them and step away. Now, most frontline leaders, as I've said, don't have the usual tools of authority, hence the dotted line here. They can't hire and fire anybody. They don't have the typical operational levers at their fingertips. So the question is, what do they do in the absence of those formal tools of authority? What the data show is that most leaders lead by communicating. The first thing, of course, is that they have to have something to communicate. They need to frame an overarching goal, a purpose, a unifying purpose. How do they communicate? Predominantly face-to-face. Leaders act with great symbolic power. Teams watch what the leader is doing, and they take their cues from the leader's question. The two actions that leaders have available to them is what it is they communicate and how they behave. You lead by being down in the organization, by having people talk to you and you talk to people. So visibility, presence is an essential component of behavior of leadership, as is modeling. I think it's essential to have a detailed system understanding. If I reflect back on the leaders I've interviewed over the years who've most impressed me, I'm struck by the extent to which they understand the myriad components of the system for which they are responsible. So let me conclude. I hope I've made the case for you for three conclusions. The first is that clinical leadership has instrumental value. The reason we're concerned about clinical leadership is because it gets better outcomes for patients first and foremost. The second thing I'd like to hope I've argued is that clinical leadership is respectable work. It's A, respectable, and it's B, it's work. It truly is work. And the work of clinical leadership, of course, is to create an environment in which clinical work can be undertaken with maximum effect. And finally, I hope I've argued that the tools are at hand. There's nothing mystical about clinical leadership. It's a matter of thinking carefully about how and what it is you communicate with your team, and thinking carefully about how you use your own personal demeanor to mobilize and focus your team's work. It's a teachable and it's a learnable skill.